So let's start with diarrhea. So the definition of diarrhea, it's a little bit vague, but just know that you can either have decreased stool consistency or an increased number of stools. If you have either one of those, you can technically meet the criteria for diarrhea. I want to talk about when you see a question on a test about diarrhea, I want you to immediately categorize it into a few different things. So the first thing I want you to do when you see somebody who has diarrhea, I want you to see how long they've been having it for. And when you look at that, then you'll be able to categorize it. Is it an acute diarrhea, which is diarrhea lasting less than 2 weeks? Or is it chronic diarrhea, which is diarrhea lasting greater than 4 weeks? I wouldn't worry so much about that subacute, that 2 to 4 week span. Just categorize it like this. And like almost every test question you'll see, they'll be very explicit. Like, hey, this has been going on for 4 days, or this has been going on for 2 months. They're not going to try to trick you with that. Later on, when I talk about chronic diarrhea, we'll go over some of the composition. So when you see somebody with diarrhea, you're first going to look at, okay, how long has this been going on for? Once you've done that, I want you to try to get any features about, is this an inflammatory diarrhea or a non-inflammatory or some other thing? And we'll go over each of these compositions in a little bit. You can get inflammatory diarrhea where it's filled with blood, mucus, white blood cells. You can get fatty or malabsorptive diarrhea. So you actually see like fat. You can get a positive fecal fat test. The stool might float. And finally, you can get a non-inflammatory or a watery diarrhea. And this can be caused by a few different things. You can get an osmotic watery diarrhea. So that's where you have like a solute. So for example, if you think about something like lactose intolerance, you might have too much of that lactose staying in your GI tract. Water will come in and drain it. You can get a secretory diarrhea where basically you don't have any osmol in your lumen, but your body, for whatever reason, is just throwing all the fluids and electrolytes into your GI lumen, causing a diarrhea. And finally, you can get a functional diarrhea, which basically means like you have diarrhea, but we don't understand why it's happening. There's no real organic cause to it. So just kind of taking a step back, I'm going to go over each of these later. But for now, just remember, when you see diarrhea, think about how long it's been going on for, and then start to try to figure out, I wonder what type of diarrhea this might be. And as I go through this lecture, you'll be able to more easily categorize these specific subtypes. So I'm just going to talk about some of these stool studies. Some of them are more important than others. And for step one specifically, they don't try to emphasize too much about, they don't expect you to know all of these different stool studies necessarily to a T, or they don't really emphasize it too much on a test, but I still think it's useful for you to understand. So as the name suggests on this slide, it's going to be pretty straightforward. Your stool white blood cells will literally just detect your white blood cells in your stool. I'm going to talk about another test later called fecal lactoferrin, which is actually a little bit more accurate in assessing whether there's any inflammatory cells in your stool. Your fecal occult blood test will detect blood. Your stool, ova, and parasite detects parasites like helminths, and your fecal fat test will detect fat. So those are the ones you've probably heard of before. Now I'm going to give you 4 stool studies that you might not have been familiar with. So let's go over those while we're here. The D-Xylose absorption test will differentiate different causes of malabsorption. And it's technically not a stool study, but I like to put it in this category because I always want you to think about it in the setting of malabsorption. And I talk about this in the small intestine lecture, and I'm just going to re-go over the D-Xylose absorption test now. It helps you to determine what is the actual cause of malabsorption. And because xylose is a monosaccharide, you only need a functional small intestine for xylose to be absorbed correctly. So for the test, it's very straightforward. You give them some of that monosaccharide, you give them D-Xylose, and then you measure their urinary D-Xylose levels. And what'll that do? Well, if the D-Xylose is correctly, let's say you have D-Xylose and it's absorbed in your cells and it goes into your bloodstream, you're going to end up excreting some of this out in the urine. So if you detect any D-Xylose in your urine, that'll tell you that the D-Xylose was correctly absorbed. And that means that this intestinal region here is working just fine. Because remember, that's the only thing you need for absorption of D-Xylose. And so if this is all working fine, then that'll clue you in to start looking at different regions that might be the problem of malabsorption, such as your pancreas, for example. And if D-Xylose was not detected, then that means that this region must not be working because it's the only thing you need to absorb D-Xylose. And so then you'll start focusing in more on an intestinal problem like celiac disease. And the reason I bring this up in a stool studies section, obviously this isn't related to the stool directly. Why I do that is because you're going to have diseases where they show some form of fat malabsorption. And once you find out that somebody has fat malabsorption, it's not like your problem is already solved right there. And then you have to start thinking, why do they have fat malabsorption? What's going on with that? Is it are there enterocytes damaged to where the fat micelles cannot diffuse in? Is it a problem with pancreatic lipases in the setting of pancreatic insufficiency? So this kind of points you in the right direction to figure out, I wonder why they have this fat malabsorption in the first place. So let's talk about another thing you might not have heard of before is the stool calprotectin. This is a calcium binding protein that you can find in neutrophils and granulocytes. And so it's actually useful to determine how much neutrophil activity might be going on within the GI tract. And as I alluded to before, this stool lactoferrin, it's useful. I remember the L in lactoferrin for the L in leukocytes. So it's a good marker of fecal leukocytes. And it's actually preferred over stool WBC count. The last thing I want to mention, which I don't recall it being tested heavily on step 1, but I saw one resource that briefly mentioned the stool osmolar gap. So I thought since we're being comprehensive here and we should just go over it so you've at least seen it once. So what the stool osmolar gap will do is it'll help you differentiate between a secretory and an osmotic diarrhea. Recall from the very first slide I talk about with diarrhea, I told you to first assess it by timing, whether it's less than 2 weeks or greater than 4 weeks. And then I said, I want you to start thinking about the different compositions. And within my watery diarrhea, I had 3 different subtypes. I mentioned an osmotic diarrhea, secretory, or functional. So the good thing about this test is that if you ever get to this stage and they give you a stool osmolar gap, it'll help you differentiate between these 2 subtypes. So let's go over what is the stool osmolar gap. So what's happening? The stool normally is isotonic to plasma. And remember, our plasma is, we'll say it's around 290 to 300 milliosmoles. With that said, just because it's isotonic, just because it has the exact same concentration globally as our plasma, the individual concentrations of electrolytes will differ quite significantly between our stool and our plasma. So what we can do is we can essentially estimate the amount of sodium and potassium that we would expect to see in normal stool and calculate the gap from that. So what do I mean by that? So our stool osmolar gap is going to be essentially our expected concentration of our stool, which is 290. And what we can do is we can try to figure out how much sodium and potassium are in our stool to give us an idea of whether this is an osmotic or secretory diarrhea. And so if we just use this equation here, and I'll explain this, I know it's kind of confusing. I showed this on another slide, so it should make sense as we go forward. So what we're going to do is we're going to use this equation to figure out what would happen to the stool osmolar gap depending on our sodium and potassium concentrations. So if we had a ton of sodium and potassium excreted in our stool, that would make this number very, very, very large. And 290 minus a very large number is going to make this whole osmolar gap small, right? If you have 290, and let's say all of this adds up to like 240, then your osmolar gap is only 50, which is actually kind of small. And so you'll get a decreased osmolar gap. What if you had decreased sodium and potassium excreted in your stool? So let's say you had low sodium and low potassium in your stool, and let's say this number, I don't know, added up to like 150, this whole number. So 290 minus 150 would be 140, which is actually a pretty high osmolar gap. So you can see the stool osmolar gap is going to be essentially the reverse of how much sodium and potassium you actually excrete in your stool. And so let me show that here. If you have excessive sodium and potassium excreted in your stool, we just mentioned that you'd have a decreased osmolar gap because this number would be very large, and 290 minus a very large number is going to give you a small number. So when would you ever have excess sodium and potassium excreted in your stool? Well, actually, let me talk about this first. I will go over that. So, and then on the contrary, we just talked about any decrease in sodium and potassium in your stool will give you a small number here. So 290 minus a small number, you'll still have a pretty close to 290, right? So it'll be a large osmolar gap. So now I want to kind of go back to what I was alluding to and talk about what scenarios would give you excessive sodium and potassium excretion into your stool. Well, that's going to happen in secretory diarrhea. And the reason it happens in secretory diarrhea is because for whatever reason, we'll talk about some of the mechanisms when we go over that Q&A section. In secretory diarrhea, what's happening is that your GI lumen is just throwing everything it can out into your GI cells, I should say, like your enterocytes are essentially throwing everything out into the GI lumen. And they don't care what they're throwing out. They'll throw out sodium, they'll throw out potassium. It doesn't matter to them. And so that's why you're going to end up getting a lot of sodium and potassium in your stool because there's no rhyme or reason to how much it's throwing out. And like we said before, just to reiterate again, if you have elevated sodium and potassium in your stool, this number gets very large. And so your stool osmolar gap in general gets very small. So you'll have a decreased osmolar gap. And you can see it in some of these conditions here. In a couple infections like cholera and ETEC, you can also see it in carcinoid syndrome and vipoma. On the other hand, so what would cause decreased sodium and potassium in your stool? So this happens, you have decreased sodium and potassium in your stool because you have a lot of other compounds present. So if you have a lot of other compounds present, that's gonna comprise most of this 290 here, this concentration. Instead of it being sodium and potassium, other compounds are in the stool that are helping to increase this number. And so what compounds would cause that? Well, anything that can cause an osmotic diarrhea could cause that. So instead of here in secretory diarrhea, everything's just getting thrown into the stool, including sodium and potassium. In the case of osmotic diarrhea, what's happening is that most of your osmoles are formed because of this, whatever you have in your GI tract, whatever is stuck there. It could be lactose in the case of lactose intolerance. It could be even fats in the case of fat malabsorption. And so all these different conditions here, what'll happen is that you're going to end up with some sort of osmol in your lumen. And because that'll comprise most of your osmolarity, you actually don't need any, you're going to have relatively less sodium and potassium excreted in this setting. Again, this right here, this stool osmolar gap, you might see a couple practice questions on it. And you may, if you do see this on the test, it'll probably be one question. So I don't want you to, if this is a little too confusing right now, that's okay. You don't have to know this specifically. I just want to give you a comprehensive framework. So if you ever have to come back or if you ever hear about the stool osmolar gap in the future, you can at least come back here and try to learn it then too. So now that we've talked a little bit about some of the timing and the composition, what I really want to do is give you some question and answer format on how are you going to actually approach this. So let's start by talking about acute diarrhea. So again, acute diarrhea is going to be any diarrhea lasting less than 2 weeks. And what's going to cause it, especially on step 1 and level 1, it's going to be an infection. Now in real life, you obviously can have chronic conditions that present acutely and then they go away and then they present acutely. Totally reasonable. When you're in a clinic setting and you have diarrhea lasting less than 2 weeks, sure, you should keep all those chronic causes of diarrhea that we'll discuss on your differential. But for step 1 and level 1, if the diarrhea is less than 2 weeks, it's going to be an infection. And so now that we know that's going to be an infection, how are we going to figure out what infection is what? So what I want you to do, it's very simple. I want you to figure out, is this a non-inflammatory diarrhea, like a watery diarrhea? Or is this an inflammatory diarrhea? And so based on this, you'll be able to categorize in your brain which condition is more or less likely, whether it's inflammatory, where it has, you see blood, you see mucus, you can have fevers, you'll see white blood cells in the stool, or lactoferrin if they measure that, or calprotectin for that matter, but more like, or you'll see a non-inflammatory or a watery diarrhea. So that's enough talk about acute diarrhea. Let's transition over and discuss chronic diarrhea. So again, chronic diarrhea on a test, just look for any diarrhea that's lasted longer than a month. You can have inflammatory diarrhea and non-inflammatory. So what I like to do when I take the test is I'll keep it simple. When I see diarrhea, I think of the timing. And once I've done that, I think of whether it's inflammatory or non-inflammatory. It keeps it very simple. And you can do this in acute diarrhea. We just did this. We just talked about all the causes of watery diarrhea first, and then we just talked about all the causes of bloody diarrhea. So let's do the same thing here. The only difference is that once you've categorized it as this watery diarrhea, there's just a few more steps. You just have to figure out, okay, I know it's not an inflammatory chronic diarrhea. So what's happening? Is it a fatty diarrhea? Is it what kind of watery diarrhea is it? Is it that osmotic diarrhea, which is related to solutes in the lumen? Is it a secretory diarrhea where your enterocytes are throwing everything into the lumen? Or is it a functional diarrhea where we honestly don't know why it's causing what it is? So fatty diarrhea, I just wanted to show you some of the subtypes while we're here on chronic diarrhea. Fatty diarrhea, as the name suggests, it's related to fat malabsorption. So normally our fat is broken down into micelles, which can diffuse into the enterocytes. However, if you have fat malabsorption for whatever reason, these fat globules can end up reaching continuing along your GI tract, and you'll excrete them in the stool, causing a fatty diarrhea. This will give you a positive fecal fat test, which shouldn't surprise you. They sometimes mention that the stool is foul smelling, or that the stool floats, or that the stool's greasy. So keep all those in mind to increase your suspicion for fatty diarrhea. Let's talk about the watery diarrhea subtypes. So the osmotic diarrhea is related to solute. So essentially you have some sort of solute, it's stuck in the GI tract, and because of that, water likes to follow solute, and so water is going to enter the GI tract and everything's going to be excreted. So because it's usually related to some sort of food intake that cannot be digested, you're going to notice osmotic diarrhea after meals. You're not going to see it at night though, because there's no solute in the lumen that's perpetuating this diarrhea. And you'll also see a high stool osmolar gap. And if I go back to the slide on stool osmolar gap, I mentioned that in the case of osmotic diarrhea, you have so much of this, whatever this solute is, you have so much of this solute in the lumen that there's not enough room for any sodium and potassium in that lumen as well. And because of that, if you have a decreased sodium and potassium excreted in the stool, you can get an increased osmolar gap. Let's contrast that with secretory diarrhea. So this is caused by active secretion of substances into your lumen. So if this is our lumen, you're going to have active secretion of all these water and electrolytes into the lumen and out into the stool. And so this will present as constant diarrhea, including at night. And that's an important distinction. Remember, osmotic diarrhea won't cause nighttime symptoms because there's nothing in your GI lumen that's promoting that release of water into the lumen and as feces. In the case of secretory diarrhea, it's through an entirely different mechanism. So you'll still get nighttime diarrhea. Another contrasting feature is that Secretory diarrhea has a low stool osmolar gap. And so right here, because it's releasing everything, including sodium and potassium, into the GI lumen, this number, if this number gets very, very high, then you'll have 290 minus a very high number, and this will end up, the stool osmolar gap will end up being a lower number, namely less than 50. And for the increased osmolar gap, it should be at least in the low to mid 100s to be considered an increased osmolar gap. But they'll give you the numbers on the test, they'll give you whatever normal values they want. So I wouldn't worry too much about that. And then a functional diarrhea, I didn't have a slide specifically. It's mostly a diarrhea without an organic cause. So it usually suggests something like irritable bowel syndrome more than anything. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.